All right, everybody, welcome to Safe Space Talk. I am Renee. I'm the inclusive midwife on IG.
And I am the Hood Midwife Keisha or _ Keisha on Instagram. You can find us there under both of those handles.
Yes, so we are going to do our ceremonial lighting today. We do this before every episode, sending out good vibes, all the positive energy. I'm going to see if I can get it done today. And today's episode is going to be on one of our favorite topics as midwives. It is on fetal presentation, pelvimetry, as well as malpresentation. And we'll go into what each of those mean here in just 1 second. I've got it. So that's for anyone going through anything big or small, trying to do things big or small, whatever it may be. That's sending you all the good vibes, let you know we're thinking about you. We want you to hang out for at least one more day and just try and find the joy in small things. Mm-hmm. And we're going to get started with today's episode. So we're going to go over pelvises. As you can see, we have a bony pelvis here. We have our musculature here. And then we have our little bambino, our baby, right here. So the first thing that we'll go over, I'll start with just a little bit of the anatomy of the bony parts of the pelvis, just as a quick overview. And then we're going to do some positioning. And as you can see, I'm in my bone outfit so that we can kind of show you guys what some of these positions do and how they work. So as far as in general, we talk about pelvimetry so that we are kind of explaining to you and you understand that it's important that you move during labor. It's important that you move during pregnancy, keeping up your general state of health. This is
like
not
the common misconception of just always rest.
Yes.
You need to always be resting.
Yes. No. Or staying in the same position, or the way that you lay in a bed with your feet elevated and not moving is okay. So that's one of our biggest things that we want you to know. Second is, to caveat to that, I feel like, I was just telling Keisha this before we started recording, I feel like I see a lot of patients, a lot of pregnant people out there like curb walking and doing all kinds of inversions and things that they find on social media, but they're doing these things 31 weeks, 32 weeks, super preterm for what they're looking to do, trying to engage their baby early and resulting in malpresentation, which mal means bad, and then presentation is how your baby's presenting in the pelvis. And so then you get babies that are kind of stuck, and we'll go into that. So doing it too early, guys, can actually be a negative. So this isn't the time to go at it, starting at 30 weeks, like boom, full frontal. And then
I think the best thing we can do at that point in time, if you want to do something, is condition your own body to be strong and get ready for labor. You can do, muscle training, stretching, cardio, all these things that get you conditioned and ready and trained for labor. But you don't have to necessarily be doing pregnancy-specific exercises.
Exactly.
Just you can modify them to make them safe for your pregnancy.
And I have on my Instagram specifically, I have a lot of videos with me in the bones, and I go over, these are for you in general. These are for you during pregnancy, during labor. Mm-hmm. So looking at those can be very helpful too. So to jump right in, I'm going to bring this really close to the camera. So we have our bony pelvis. So on the inside where I have this, so if you consider this is just your pelvic bones, but consider this your pelvic girdle. So we want the baby to go into the pelvic girdle and seat there. So that would be right around, that would be like right around here. So inside of this, you can see that I have a pink line drawn, and that is the pink line. So that is going to be your inlet. So we want the baby to actually get into the inlet. They have to sit there first. So that's the first place we want the baby to go. The second space is going to be your mid pelvis. And if you look inside, I have a line drawn there, and it goes around, and you'll see that there's a bone right here, and it's the ischial spine. So it's this bone right here. That is called your mid pelvis. And then you have here and here on the outside.
And this arch is really important in that.
So when you sit like a skeleton, like a Halloween skeleton on a chair, this is what would touch the actual chair, right? If it was just bones, that's your outlet. So when we talk about opening your outlet, this is that space that we're talking about there, if that makes sense. That's going to be obviously the last place that your baby needs to descend through before they come out, because at that point, this is where they are. I think I just hit the microphone. So they would be, here's that bone there. So they would be where your vagina is. That's where they're lined up, if that makes sense.
So you see, it's not as easy as just being in good position to actually have a successful vaginal birth, because there's no way for a baby to come down in one certain position and stay that way that they will come out successfully vaginally.
Exactly. So we call them the cardinal positions of labor, and I'll have Keisha kind of go over that a little bit more, just because of the fact that it's specific ways that the baby turns. But the way I like to describe it is that you can take a key. You know how you watch a scary movie and they try to put a key in the door and turn the door, and you swear that's the one time your door never opens when you try to put the key in. But you have to line it up just right. You feel it kind of give a little bit, and then you can turn and unlock the door. That's kind of like what your baby has to do. They have to come down to where your pelvis matches it. And then they can kind of descend and transition as they need to. But not every pelvis is built the same. So we'll have Keisha kind of take away that part.
Okay, so like Renee said, we're going to go through what is called the cardinal movements of labor. So these are the movements that your baby has to go through to successfully come out vaginally. So usually we start with the baby with what we call an OT position. So OT, occiput is the O, and that means transverse. So usually one side, we're going to have either coming in, looking at one hip or the other. So this is the first one. They kind of engage in that top, the inlet, that part of the bone, that pink circle that she was showing, that's where they engage into. So once they hit that, that means they are engaged. Usually this can happen before labor. For some first-time moms, their babies will kind of come down, and you can notice like your baby dropping into your pelvis. You know, you feel like you can breathe a little bit easier. You feel more pressure down in your pelvis. So that's your engagement. Then you have what's descent, which simply means they come down further. Then we have flexion. So that means we flex their heads. You want their heads to be as flexed as possible, because this is the smallest part of the head. You don't want a baby to be coming out with the biggest part of the head. You see this is wider than just the top of it. So this,
So that would be, this is the diameter of the baby trying to come out of your pelvis if they do not flex. If they do flex, see how much narrower that is, and it can come through.
So that's more of a smaller presenting part to make way for the rest of the body.
So they come down, they engage, they descend, they flex their head.
And the flexion actually occurs because if you think about it, they're now at a point where they're reaching these muscles. So their head is being flexed against the muscles, actually. It's not just something that they do and they, keep their head down. It's actually
because some of them don't do it.
Yes.
Which is why this is so important.
And then you have internal rotation. So this is going to be your first actual turn that your baby has to make. It can go one of two ways. This is where you have the differentiation of some people having a super long labor, back pain, or the ones that kind of keep on going and keep trucking along. So you can either turn towards the mom's spine, the back of the head going to the front. That is what we call an OA position. This is the optimal position. It makes it easier. You usually don't have as much back labor, and the labor times are usually a little bit shorter, comparatively speaking. You can also turn where they turn looking out with their back of their head is to your butt. This is called OP. So it means, again, occiput is to the posterior. So these are when you have back labor. You can see how there's pressure literally on mom's back. They have their bony parts up against
the biggest bony part
up against these bones down here. So you have a lot of back pain, feeling like you have to poop the entire time, even though you're nowhere near pushing. That's what a lot of those things come from, is baby simply being in that OP position.
Which is also called sunny side up. Some people refer to it as sunny side up.
Exactly.
They're the babies that come out looking at the ceiling. Like that.
So when you access your baby in position, it's more than just are they head down. It is, are they in position? Are they facing where they should be
facing?
Yeah. Internally. Okay, so then you have the internal rotation. Then
let's say they did it the right.
So let's say they did it the easiest way, supposedly
for some pelvises.
Then you have so we have the internal rotation, and then we have extension. So then when they come out here, this is the part where we want this arch to be nice and wide. On a woman, this arch is a lot wider than it is on a man. On a man, it's usually about this small. But you see, a baby can't get through this. So for a female pelvis, it has to have this wide enough arch for the baby to do this. So now you see they're still inside, but their head is now extending up past this outlet bone.
So that's the extension, and then after they extend, they do the internal.
Then they do a rotation, internally. So they'll turn to usually a side because, again, they have to be able to pass their whole body through. This is going to be harder to pass their body through. So they kind of turn to one side
or the other. And it's for the shoulders.
And then the shoulders maneuver under this arch right here. This is where a lot of babies will get stuck up, and it's called a shoulder dystocia. Well, I don't want to say a lot, but some babies will get stuck here, and it's called a shoulder dystocia. That is a medical emergency, but a lot of times if you allow the baby to have time to fully do their turns without rushing them, then we're not creating that shoulder dystocia in the first place. I think I've had like one sticky shoulder incident, and it was just a really fat baby. Like it wasn't anything really to do with positioning. It was just a fat baby.
I just love how, as medical providers, though, we do not want to give a baby one whole minute to literally make a decision and turn their whole body to make their whole life plausible. But we want to go ramming and rushing, and after 1 minute, oh, that was a dystocia. Ma'am, how long did it take you to turn and get into your car?
Yeah, it did. And if you look at the WHO, I think they say preferred time from the birth of the head, which is the head is out of the vagina, and to the body being out can be up to 90 seconds or 1 to 2 contractions. So, but in a hospital, a lot of times, as soon as the head comes out, they want immediate delivery of the body.
Within 60 seconds is the clinical norm in hospitals practicing right now.
Right. So there you create this rush situation. And you can see if the baby hasn't fully turned, it's extended, and now you're trying to pull it out. The shoulder can't even maneuver under this bone
because they haven't made their decision on where they're going based on your pelvis and their size.
Yeah.
So I remember going to classes, and I'm like, give the baby at least 1 minute to decide before you intervene, and they're looking.
And if you
I can't imagine staying there for a whole minute waiting, and I'm like, it's a baby coming through a pelvis. They're blind.
Still a cord attached to the cord. Yeah. So it's not like they're being suffocated right now. They're actually probably getting a good, what's called thoracic squeeze. We squeeze their chest in because, there's no air in their lungs. So that whenever they do come out, there's a recoil and they want to take in that first breath of air. So allowing them to get that, and it also squeezes all that liquid out. That lets them drip out of their nose, comes out of their mouth.
So I say real quick, let's do it side by side, not in the pelvis, so they can actually see them. So we'll go over them real quick so they can look at the baby do it. So we have engagement.
So we have engagement, then you have descent, which is coming down, and then you have flexion, so flexion of the head, and then you have the internal rotation, so they're going to rotate. Then you have the extension of the head, so their head comes back out. Then you have the external rotation, so they turn again to the side, and this is more like this at this point. And then you have expulsion, which is them actually coming out. So those are your cardinal movements, and you see that if the baby were to just try to transverse the pelvis going one way, you would not be successful. Like these shoulders probably couldn't even pass through this inlet right here. So, and you see that side to side, it's bigger than it is front to back. So they have to utilize the most spaces in these uneven circles to try to wriggle their body through. So that's why you see that just being head down does not mean
is not enough.
Good position.
Exactly.
Yeah.
All right, everybody. So we're going to go ahead and go into the positioning part of the video. So we're going to start with the simple, the inlet, the mid-pelvis, the outlet. A quick, easy rule to follow is that the inlet, you want your knees to be out, which sounds funny. The mid-pelvis, you want your knees to be in. And for the outlet to open, you want your knees to be together and your feet apart. So if I wanted to focus on my inlet, which was our pink line, what I'm going to do is take my knees and bring them out this way because it's opening this part the widest. So this is the widest part of me right now. So this is where the baby is trying to nestle for that engagement. Now, let's say we want descent, which is going to be our mid-pelvis. I'm going to take my body and bring my knees parallel. So now you can see that the widest part is right here, if that makes sense. So this part of me has now substantially gotten wider, if you can tell. For me to bring this part where these bones are together, I'm going to take my knees, bring them inward and my feet outward. And what happens is, it's harder with this. Hold on, got to bring it up because you have to think of where my bones actually are. Now, where my bones are, see how much wider that is? Because my feet are together. So, my feet are wide apart. So my knees being together brings this part
This
out.
bone, your leg bone, is actually, it moves, it rotates in this portion and right here. Yep, right here. Yeah. And so rotating it out gives you more space in getting into that outlet part where baby's trying to come out.
So if you can imagine, we're just like this now, and then as I bring it this way, they're going to be closer because this part is going to be wider and more open right up here. So we've got that part, and then we'll go into some positions for labor.
So there's a ton of different reasons why you might use positioning, or you should use positioning in labor. I'm a firm advocate of you should never be sitting still for longer than a few hours in labor. Like, yes, get your rest, get your naps at the beginning if you need to, but there's work to be done. And to facilitate, even if it's an induction, a natural labor, however you want. If you're not one of those people which labor comes naturally to, which some people, they're spitting babies out, and some people it's a struggle for each inch, for each inch of descent, for each dilation centimeter, it is hard. So utilizing tricks can sometimes be that make or break between having a C-section and having a vaginal birth. So if you're starting off, say this is a great position if your baby's super high. If you're like a third or fourth time mom, your baby hasn't descended yet, all of a sudden they're like, oh, you have to be induced. These are some things that we can try to do to get your baby to engage. So we want to open that pelvic inlet. So again, we're thinking, your uterus is sitting right here. We want to open this as much as possible. This little pink line, that's what we want to open. So those are going to be your upper hip openers. And we're going to do things that kind of try to force baby down into that position. Mm-hmm. So like what Renee's going to do is we call it Walters. And it is quite uncomfortable for the laboring person sometimes. It can be painful and has to be done over the succession of several contractions to allow the uterus to actually do that work of moving the baby down into the direction we want it to.
So I usually will take something and put it here because this part of my body is going to end up being bent on the bed. So
you're literally like trying to extend and force that baby down.
And so then you're going to have your body hanging off of the bed. This part of your body is going to be on the bed, and then you literally allow yourself to drop. So this is the Walshers. So what it does is right here, where we're trying to get engaged, this is going to be at its widest part because we've got everything going downward. And so the baby literally drops.
It has nowhere to go. Down. It cannot go anywhere else.
Your symphysis pubis bone is literally like this bone here is tilted downward, so the baby has that optimal space to tuck right on in there.
So that's one position we can do. Another one, which is, I think, pretty common, I see it a lot, and what people think of birthing positions, they think of a lot of wide knee positions, the ones that you see in the hospital. They're like, hold your knees back, wide knee. Yes. Those are actually more good for, again, the inlet, so the beginning of labor. Yeah. So these are going to be positions where you're doing wide knee squats.
So this is when you're going to take your legs. So when your baby has not even engaged yet, you're going to squat, but your knees are going to be out. You're going to grab onto something and you bring yourself down into that position.
And you can be hugging your partner. Mm-hmm. You can be hugging how she is. Sheet. Yes, a sheet, a labor ball to kind of wrap around yourself. Yeah, these are, and you see again how her pelvis would be open at the top. You're forcing baby down into that pelvis.
And I'll turn around like this so they can kind of.
Yep, and you let those contractions do the work. Mm-hmm. So those are two positions you can use to get your baby to come down into the inlet.
Yes.
So now after we've done the inlet, which is, the top of the pelvis where the baby's coming in, we have to now focus on the mid pelvis. This is one of the trickier circles to navigate. And if you have a stalled out labor, this is most likely where you're going to get kind of caught up on. This takes a lot of asymmetrical movements, or you don't want your pelvis to be, each side the same. You want to be having one leg, doing something versus the other and kind of doing that. So we're going to demonstrate a couple of those positions for you today. So this one I really like if you have an epidural, because you can still do it. And you can do it with just some hospital pillows. You don't need any like peanut ball. We prefer the peanut ball, but not necessary, and can be modified as you need for your epidural positioning. So we call this one the fire hydrant. So you can see that. So you can see that this is an asymmetrical position. Legs are not even with, and this is would be if if you don't have an epidural, you can easily modify this one and actually lay onto your side if you do have an epidural and you don't have that muscle strength or capability or control, and you can literally, and this is how a lot of people sleep anyway, so it's not that far off, but you want to make sure you're continuing to have a little bit of movement. You can have someone rock your hips. You can see if you can do them yourself. But you see it's very asymmetrical. Your legs are not doing the same thing. So that one's called a fire hydrant for reasons that you can imagine.
Mm-hmm. And then the second one, whenever I laid, is called exaggerated runners. So fire hydrant was like a dog peeing on a fire hydrant, obviously. So, and then exaggerated runners was whenever I was laying down. And then I like to use proposal position. So I don't think this is actually I don't think it's called that, but that's what I call it. Where you basically have the patient, and you can do this with an epidural. Do not be fooled. You have one leg down, one leg up, and you can hold on to like a peanut ball if you need it to. But you're basically
the bed.
Mm-hmm, but you're basically bringing your body. You poke your butt out, tuck your butt up, poke your butt out, and you tuck your butt up. And the rationale behind that is because you're actually navigating the pelvis, bringing it back, bringing it up, bringing it back, bringing it up. And you see how you already have one leg up, one leg down. Now you're tucking, and you're extending. So you're giving that baby that space to kind of make good decisions, if you can see what I'm saying. So that's another position that I use for the mid pelvis is proposal position. And like I say, you can have the peanut ball or the birthing ball just right here, or you can hold on to the back of the bed. The nurse can lift the bed up for you and you lean over it, or you can even be in it on all fours like this because your belly's going to be right here and you're just leaning forward, or you're tucking and going back. The tucking and going back is harder when you have an epidural just because of the sensory notion of it. So more than likely rocking is easier. But if you don't have an epidural, you can do tuck and extend.
And you want to make sure you do both legs. You don't want to just hang out on one side. Yeah. And sometimes even always in labor, we can kind of tell which side your baby's favoring by the cervical exam. So sometimes if that information is available, you can ask your nurse and make decisions based off of that. So you want to kind of, if there's more cervix on the right side, you're going to be working that right side a little bit more. If there's more cervix on the left, you're going to work that left side a little bit more.
Yep. So that's the mid pelvis. That.
So finally we get to the outlet opening positions. This is when you're pushing. This is when you're maybe 10 centimeters, but your baby's still high up in your pelvis and hasn't really descended down yet. These are the positions we're going to be utilizing for that. So again, like we said, we want our knees inwards for these types of situations. So you see knees are inwards, feet are out. You can see pelvic bones are moved, or leg bones are moved out the way and opened, and then these actual two pelvic bones have a little bit more space for the baby to actually emerge and come through the vagina that way. So that is one position you can push or even labor in. It's comfortable because you can be laying down on pillows, as Renee was. And then this is one that I like to use for, like, say I have a patient that has an epidural. They may be complete, but baby's way high up there, and we don't want to be pushing for hours on end, and we want to give a little bit of what's called passive descent, where the uterus just does some work and pushes baby down in the pelvis, but we're not actually doing any pushing. So you can see how her knees are down and her feet is upward, again moving that bone out of that outlet area, rotating it and making more space for the baby to move. So easy, you can use a peanut ball with this, but really we want to focus on getting something between the ankles so that the knees are close again and the ankles are spread apart. You could do this peanut ball, pillows, so it should be pretty easy to replicate in the hospital with epidural, without an epidural. It's a good resting position as you're doing some work as well.
And you just make sure you do both sides of them. And so this would be me if I did that on the opposite side. So they can kind of see it from behind.
Yep, and you see again, under this pillow, knees together, And then feet are the most spread apart in this position. So we hope you enjoyed our small, concise, little brief video on visuals on good labor positions, things that you might utilize. There is a plenty of information out there. Renee has many, many videos on her Instagram page. I'll put the Instagram handle down below again. And you can literally visualize with her bone suit how these are helping you progress through labor.
Yep. And make sure that you reach out for any questions. There's so many more things that we can go over. We just can't fit them all in one video. So if you have any questions or anything like that, make sure you always reach out to us. We have already blown out our candle by doing all of the positioning and work that we did today. So the air just was moving. It's an ice tired, boss. I can't do it. So we've blown out our candle just without our consent. So other than that, you guys, we really appreciate you guys hanging out with us today, learning some of these positions. Like we said, obviously follow what your healthcare provider is telling you. Know to advocate for yourself in the hospital. It is not okay to stay semi-Fowlers, which is this position, your whole labor. That is not okay. That's not normal. Do not let us get away with it. We should be repositioning you more than every 2 hours, I would say.
I'd say hour, 30 minutes, depending on what stage of labor you are in. So, yeah, definitely at the beginning, you're not having to be as aggressive as certain things. You're letting things
the body happen.
But,
yes.
Definitely if mid-pelvis and beyond,
you need to be more active.
Yes.
And the peanut ball actually has a disclaimer that they suggest their positions to be 45 minutes, which I didn't know this until I actually read it. They say 45 minutes is where they describe it and then change again.
Oh, okay.
So I've started doing that a lot more with my patients. Whenever I position them on the peanut ball, it's 45 minutes and then I reposition them, which I know there's nurses out there that's going to lose their mind and kill us all. 45 minutes. For that. I just got done positioning her. I know, but then it's the 45 minutes. So, but we hope you guys enjoyed this information and that we can help you guys utilize it for healthy, safe births that are productive and everything that you would like, because it's not just healthy mom, healthy baby. It's mentally healthy experience, mentally encouraging, empower experience, and healthy patient, healthy parents, healthy family.
Yeah, and as you can see, this is the big debate. She was in positions in the pushing stage that did not require her to be on her back. So that's always what I hear. Mm-hmm. Hospitals force you to be on your back. Not necessarily. So, but you have to maybe come armed with some positions that you would like to utilize instead, because if they're wanting you on your back, they're not going to give you those positions. So this is the things you need to arm yourself with mentally to come in to kind of know how you want your labor and birth to go.
Awesome. Yeah. I agree. Thank you guys so much. We'll talk to you guys next time.
Bye.
Bye.
God damn it.
That makes sense. This sounds about right for us. What even occurred?
And that should help. All right.
And make sure that I actually look right, because I think because my legs are so long, it's harder for me to show it without a peanut ball.
You want to lay this way so you can act like you're laying in a hospital bed?
Yeah, we can do that. But then you'd also need to be able to get around to be able to show the pelts too.